Anxiety. Feeling of uneasiness, uncertainty, and apprehension from a real or perceived threat. An issue with symptoms become severely debilitating and interfere with normal functioning. Mild anxiety. Reality perceived in sharp focus, learning enhanced at this level. Moderate anxiety. The ability to think clearly is impaired, may only retain certain things that are seen or heard in the environment. Severe anxiety. Learning, problem solving cannot happen. Unable to notice some things going on in the environment, may be dazed and confused. Panic anxiety. Most extreme level, dysregulated behavior, unable to notice what is going on in the environment, loses touch with reality. Separation anxiety. Excessive fear or anxiety when separated from an individual to which the client is emotionally attached. Inappropriate levels of concern being away from a significant other, a normal part of the infant development. Characteristics of adult separation anxiety disorder. Worry, shyness, uncertainty, fatigability, no self-direction. Cynophobia, fear of dogs. Anthrophobia, fear of people. Mesophobia, fear of germs. Acrophobia, fear of heights. Zoophobia, fear of animals. Agoraphobia, fear of being out in public places, but more specifically defined as a fear of being vulnerable and unable to get help or escape the setting. Social anxiety disorders. Severe anxiety of fear provoked by exposure to a social or performance situation, for example, public speaking. Panic disorder. Sudden onset of extreme apprehension or fear associated with feelings of impending doom. Normal functioning can be suspended. The treatment is CBT, mindfulness, visual imagery. General anxiety disorder, or GAD. Clinically significant distress or impairment in social, occupational, or other areas of functioning. Excessive anxiety and worry for 6 months or more. Worry cannot be controlled. GAD is associated with 3 or more of the following: restlessness, feeling on edge, fatigue, irritability, difficulty concentrating, sleep disturbance, and muscle tension. Medication given for anxiety: buspirone, benzos, and beta blockers. Obsessive-compulsive disorder, or OCD. An anxiety disorder characterized by unwanted repetitive thoughts or obsessions and or actions, which are compulsions. Symptoms of OCD: issues of sexuality, violence, contamination, illness, or death. Body dysmorphic disorder: exaggerated belief the body is deformed or defective in some way. For example, false assumptions, fear of rejection, perfectionism, and conviction of being disfigured lead to emotions of shame, disgust, and depression. Hoarding disorder: characterized by persistent difficulty in parting with possessions regardless of their actual value or usefulness, usually starts from a stressful event. Trichotillomania, hair pulling disorder. Trichophagia, hair eating, chewing and biting. Excoriation, skin picking to the point that pain, sores, scars, and infections occur. Nursing interventions for anxiety: assess for physical and safety needs, maintain a calm manner, remain with the person experiencing this level of anxiety, minimize external stimuli. Treatment modalities: individual psychotherapy, cognitive therapy, behavioral therapy. OCD medication: fluoxetine, sertraline, and clomipramine. Post-traumatic stress disorder, or PTSD. Reaction to extreme trauma that causes pervasive distress. Trauma may involve threatened death or serious injury responded with intense fear, helplessness, or horror. Who is most at risk for developing PTSD? Children who have been abused or neglected and military. Symptoms of PTSD. Nightmares, night terrors, hypervigilance, hallucinations, intrusive traumatic thoughts, and memories. PTSD nursing care. Awareness of environmental triggers. Watch for hyperarousal and startle response. Stay with the patient and listen to them. PTSD treatment. Use of an MAOI antidepressant helps patients sleep. Use of tricyclics helps prevent re-experiencing the trauma, and use of SSRIs. Acute stress disorder, or ASD. Reaction to an extreme trauma, which results in stress similar to PTSD but doesn't last as long, less than a month. Adjustment disorder. Precipitated by a stressful event like a breakup, retirement, or illness, usually leaves within 6 months. Dissociative disorder. Occurs after a significant adverse experience or trauma, and the response is a severe interruption of consciousness, unconscious defense mechanism that protects the individual against overwhelming anxiety. Depersonalization disorder. An alteration in the perception or experience of the self so that the feeling of one's own reality is temporarily lost. Total loss of all memories related to the situation. Derealization disorder. An alteration in the perception of the external world so that it seems strange or unreal. Dissociative amnesia. Inability to recall important personal information, often of a traumatic or stressful nature or event. Subtype of dissociative amnesia. Fugue. Sudden, unexpected travel and the inability to recall one's identity or information about some or all of the past. Dissociative identity disorder. 2 or more distinct personality states that are composed of different memories, behavior patterns, and social relationships. One personality is usually more dominant, usually develops as a result of childhood abuse. Somatic symptom disorder. Excess concern, preoccupation, and fear when focused on physical symptoms. Common symptoms of somatic symptom disorder: fatigue, dizziness, headache, back pain, high level of help seeking going on multiple providers since he or she can't get a diagnosis. Hamilton Anxiety Rating Scale. Used to identify symptoms of anxiety and somatic symptoms: grinding teeth, jaw tightness, pains, and aches. Illness anxiety disorder. Extreme worry and fear about possibly having a disease. Misinterprets body sensations and have intrusive thoughts that can't be stopped even when the person knows they're unrealistic. Conversion disorder. Functional neurological disorder with deficits in voluntary motor and sensory functions, including paralysis, inability to swallow, movement disorder, gait disorder, and numbness. Labile indifference. Lack of emotional concern regarding life-altering symptoms. Malingering. Deficits in functioning that are deliberate and intentional. Gain for something specific, for example, avoiding work or financial gain. Malingering is deliberate, on purpose, usually to get out of something. Factitious syndrome. Deceives others by purposely hurting self or others. Gain is for attention and sympathy. Symptoms mimic other diseases. Pseudo-seizures. Seizure-like activity such as twitching or loss of consciousness without electrical disruptions in the brain. Autism spectrum disorder. Abnormalities in the brain structure and function cannot be cured. Medications for autism. Methylphenidate may reduce hyperactivity. Ariprazole and risperidone and other SGAs reduce irritability and compulsive behavior seen in autism. Autism disorder characteristics and behavior. Absence of or very limited language, no interpersonal skills, no friends, no eye contact, rocking in place for long periods of time, and repetitive behaviors to calm self, spinning and headbanging. Intellectual disabilities. Mild to severe impairment in conceptual, social, and practical functioning. Intellectual functioning deficit. Deficits in reasoning, problem-solving, planning, judgment, and abstract thinking. Social functioning deficit. Impaired communication and language, interpreting and acting on social cues, and controlling emotions. Daily functioning deficit. Deficits in managing age, appropriate activities of daily living, functions at school, and performing self-care. Causes of intellectual disabilities. Pregnancy or birth complications account for 40%. Environmental and social neglect account for 20%. Intellectual IQ. Average IQ in most people is between 80 and 120. Below average is less than 70. Nursing care teaching for intellectual disabilities. Mild to moderate delay will be able to attend school. Behaviors could be difficult for teachers to manage. Help family to have realistic expectations, and help parents to understand that if limited intellectual functioning, a teenager may act like a young child. Down syndrome. Abnormal cell on division on chromosome 21. Intellectual disabilities, developmental delays, and physical issues. Fragile X syndrome. Inherited, caused by mutation on the X chromosome, wide range of physical, developmental, and behavioral and emotional issues. Fetal alcohol syndrome, caused by alcohol exposure during mother's pregnancy, low birth weight, learning disabilities, poor memory, speech and language delay, and hyperactivity. Traumatic brain injury, mild or severe trauma that can result from a violent impact to the head. In infants, persists crying and irritability. In children, it changes in eating habits, unable to pay attention, changes in sleep and play, lethargy, and language delays. Complex development disorder, Tourette's syndrome. Multiple genes involved causing multiple motor and/or vocal tics for more than a year. For example, mild tics, rapid blinking, shoulder shrugging, and throat clearing. Coprolalia, the involuntary utterance of obscenities, profanities, and derogatory remarks seen in 10% of Tourette's diagnosis. Medications used to treat Tourette syndrome: haloperidol, risperidone, and ariprazole. Attention deficit hyperactivity disorder, or ADHD. Lack of attention, highly distractible, trouble following directions, difficulty participating in peer group activities. ADHD medication: methylphenidate or atomoxetine. Mood dysregulation disorder, or DMDD. Irritability, anger, frequent temper outburst 3+ times a week, and diagnosed between 6 to 18 years old. Intermittent explosive disorder, IED. Repetitive, unprovoked aggressive behavior, lack of impulse control, will feel regret when anger passes. Oppositional defiant disorder, or ODD. Pattern of anger and defiant behavior with poor impulse control, likely to act out around parents. Symptoms of ODD: irritability, unwillingness to compromise, refusal to accept responsibility for misbehavior, directed toward parent or caregiver. It can be outgrown. Meds for ODD: cannot cure disorder, but Dalva-Prox. Nursing and parent interactions for ODD. Parents and caregivers need to ignore and turn back on child when maladaptive behavior happens. When acting out, remind the child of the behavior contract he or she signed. If the child refuses parents' efforts to comfort, keep the environment safe. Conduct disorder. A persistent pattern of deviant behavior involving aggression to people or humans or animals, destruction of property, deceitfulness of or theft, or serious rule violations. You can give risperidone. Symptoms of conduct disorder: aggression to people and animals, physically cruel to people and animals, physically abusive to parents and family, often bullies to others, initiates fights, destroys property, sets fires, runs away from home. Interruptive explosive disorder, or IED, hostility, impulsivity, and recurrent aggressive outbursts. Causes and treatment of IED: heredity, childhood abuse, brain function and chemistry. The treatment is SSRIs and CBT. Personality disorders. Psychological disorders characterized by inflexible and enduring behavior patterns that impair social functioning. 10 personality disorders grouped into 3 clusters. Cluster A, odd or eccentric. Usually not hospitalized for the behaviors, they are on the spectrum. Cluster A, schizotypal personality disorder. Aloof and isolative, live in their own world, may be psychotic under stress, distorted thinking, magical thinking, illusions, and ideas of reference. Cluster A, schizoid personality disorder. Inability to form personal relationships, inability to respond to others in an emotional manner, prefer to work in isolation, display discomfort in human interaction, cold and aloof, inappropriately serious about everything. Cluster A, paranoid personality disorder. Distrust of others, constantly on guard, hypervigilant, ready to react to any threat, real or imagined, insensitive to the feelings of others, tense and irritable, feels others are trying to take advantage of them, attribute their shortcomings to others, and do not take responsibility for their own behavior. Cluster B, dramatic, emotional, or erratic. Antisocial, borderline, histrionic, and narcissistic. Cluster B, borderline personality disorder, BPD. Intense fear of abandonment, extremely erratic and dramatic, emotional liability, splitting, dichotomous thinking, fluctuating attitudes towards others, ideations and devaluation, and self-harm. BPD causes: genetic, serotonin dysfunction, limbic system and prefrontal cortex abnormalities. BPD diagnosis: frantic efforts to avoid real or imagined abandonment, pattern of unstable and intense interpersonal relationships, markedly or persistently unstable self-image, mood instability, chronic feelings of emptiness. Cluster B, narcissistic: self-centered, lack of empathy, exploit others to fulfill own desires, fragile self-esteem, feel superior, thus entitled to special rights and privileges, an exaggerated sense of self-worth. Cluster B, antisocial personality disorder. Exploit and manipulate others, disregards the law, disregards the rights of others, difficulty establishing stable relationships, experiences no guilt and no remorse. Cluster B, histrionic personality disorder. Dramatic, attention-seeking, seductive, gregarious, excitable, need for approval, easily influenced, independent, highly suggestible. Cluster C, anxious and fearful. Avoidant, dependent, obsessive-compulsive. Cluster C, avoidant personality disorder. Sensitive to rejection, lead a socially withdrawn life, awkward and uncomfortable in social situations, lonely, express feelings of being unwanted, and view others as critically betraying. Cluster C, obsessive-compulsive personality disorder. Overly disciplined, perfectionistic, preoccupied with rules, fear making mistakes, and flexible, lack spontaneity, and serious and formal. Nursing diagnosis for BPD. Encourage the client to examine their behavior. Be available without reinforcing dependence. Rotate staff members. It prevents client dependence on one nurse. Recognize staff splitting. With client, explore feelings of abandonment. Nursing interventions for cluster personality disorders. Define acceptable and non-acceptable behaviors. Explain the consequences of violating of limits. Do not use the words you should. Instead, you are expected to. Provide positive feedback for acceptable behaviors in matter-of-fact manner. Maintain milieu. Discuss past behaviors with outcomes. Therapy or treatment for personality disorders. Interpersonal psychotherapy, long-term therapy to understand or modify behaviors. Psychoanalytical psychotherapy focuses on unconscious motivation, need for seeking total satisfaction from others. Milieu group therapy is appropriate for others who respond more adaptively to support and feedback from peers. Eating disorders. Extreme, harmful eating behaviors that can cause serious illness or even death. Anorexia nervosa. Can be restricting or binge eating purging type. Significantly underweight, bradycardia, hypotension, edema, and lanugo, amenorrhea, metabolic changes, infertility, and cardiomyopathy, cardiac failure. Bulimia nervosa. Episodes of binge eating followed by purging. Purge the extra calories by vomiting, laxatives, or excessive exercise. Symptoms of bulimia. Normal to slightly low weight, dental caries, tooth erosion, parotoid swelling, gastric dilation and rupture, calluses on fingers, which is Russell's sign, peripheral edema, anemia and leukopenia, muscle weakening, abnormal laboratory values, uses electrolyte imbalances, and cardiomyopathy, cardiac failure. Binge eating disorder. Significant binge eating episodes followed by distress, disgust, or guilt, but without the compensatory purging, fasting, or excessive exercise that marks bulimia nervosa. Binge eating symptoms. Normal weight to obese, consuming massive amounts of food in short time frames, out of control eating behavior, self-loathing with depression, disgust, sadness after eating, secretive eating. Eating disorder nursing interventions. Acknowledge patient struggle, make plan of care with patient, conduct weighing in on a schedule, no negotiation of acceptable weight, vital signs and labs, eating at a set time and observed, be firm and matter-of-fact about behaviors that are unacceptable. Eating disorder treatment. There are no medications specifically for eating disorders. Medications are to treat the symptoms, SSRIs and SNRIs, fluoxetine for anorexia nervosa and bulimia nervosa. Factors that increase the risk of child abuse. Child disabilities, social isolation of families, domestic abuse and parents' history, socioeconomic factors, poverty, low income, family dynamics. Child abuse, physical. Any injury that cannot be explained, burn, fracture, abdominal or head injury, scalding burns with clear demarcation, marks from cords, belts, or rope, multiple fractures and various stages of healing, and sedation from over-medication. Child abuse, sexual. Fearful behavior, swollen labia or rectum, sexually transmitted disease, abdominal pain, UTI, enuresis, vaginal tears, genital bleeding or pain, sexually inappropriate behavior for child's age, injuries in different stages of healing, lice, cigarette, or other types of burns on the body. Child abuse, emotional, verbal, terrorizing, exploiting, rejecting, isolating, neglect, parentification, and domestic violence. Child abuse, neglect, physical, medical, educational, or emotional. Role of the nurse in child abuse. Record all assessment findings, must be reported to CPS as child-indicated abuse or neglect. Maintain neutral. Ask caregiver what caused bruises. Observe how child responds to questions. Domestic violence. Power and control are main themes. Victims often believe it is their fault, will make excuses for abuser. Common to see low self-esteem incest survivors. Victim often returns to abuser at least one time. Pregnancy can be a trigger. Phases of partner abuse. Tension building, acute battering, loving respite, the honeymoon phase, and triggering event. Behavior and feelings seen in survivors: rage, guilt, depression, fear. Abuse victim resources: list of community resources, physical and virtual support groups. Rape: used by perpetrator to show power and dominance through sexual aggression and violence without consent. Types of rape: date, out at a party or on a date. Statutory, sex with individual under 16 to 18 years old. Age depends on state. Marital, spouse does not consent to event. Or gang, group of individuals participate in rape of a single victim. Nursing care for a rape victim: provide physical and emotional support while evidence is collected. Explain all activities. Victim may feel threatened by some procedures. Ensure victim understands no shower, douche, or change of clothes while evidence gathering. Overall goal is to get victim back to previous level of lifestyle and functioning. Rape trauma syndrome, or RTS, a set of PTSD symptoms that have been linked specifically to those who have experienced severe violence in the form of sexual assault. Rape trauma syndrome stage 1. Acute. Occurs moments, days, or weeks after sexual assault. Behavior upset, emotional shock, and disbelief. Care includes letting the client know he or she is safe and not to blame for the event. Rape trauma syndrome stage 2. Outward adjustment, starts after acute, lasts weeks, months, or longer. Victim does not appear to be as traumatized as an acute phase but still experiencing trauma. Rape trauma syndrome stage 3. Resolution or integration, comes to terms with the event, may not forgive assailant or be sexually comfortable again, makes concerted effort to move forward, counseling, support groups, participates in volunteer activities. Human trafficking, sex act performed by a person under 18 that is induced by force, fraud, or coercion, can be sexual and/or laboring, must be reported to Florida Abuse Hotline. Signs and symptoms of human trafficking. Victim is overly fearful, submissive, tense, or paranoid. Defers to another person before giving information. Answers appear scripted. Physician inquiries present such as branding, name tattoos on face or chest, tattoos about money and sex or pimp phrases. Clothing is inappropriately sexual or inappropriate for weather. Live with employer. Multiple people living in cramped conditions. Elderly abuse. May be physical, physiological, psychological, financial, or sexual. Neglect is most common form. Victim often denies abuse by family due to fear of retaliation, embarrassment, dependence on abuser, familial protectiveness, and fear of displacement. Elderly abuse, psychological. Depression, withdrawal, increased agitation, insomnia, and anxiety. Elderly abuse, physical. Bruises, welts, lacerations, burns, missing hair, skeletal dislocation, and fractures. Elderly abuse, financial. Elderly abuse, financial. Assets do not match living conditions, lack of funds for living expenses. Elderly abuse, neglect. Hunger, lack of hygiene, inappropriate dress, unmet physical or medical needs, sedation, and abandonment. Elderly abuse, sexual. Pain, itching in genital area, bruising or bleeding in vaginal area, unexplained STD. Nursing role in elderly abuse. Ensure victim is safe, complete thorough assessment. Healthcare workers are mandated to report any suspicions of abuse to elderly or vulnerable disabled adults. End of life grieving stages. Stage 1, denial. Stage 2, anger. Stage 3, bargaining. Stage 4, depression. Stage 5, acceptance. End of life mourning. Mourning process similar to process of healing after a physical injury. There's 4 stages: shock and disbelief, developing awareness of the loss, restitution, and recovery. Anticipatory grief. Can be by family member or in anticipation of own death. is believed to be able to facilitate the grieving process, may isolate the person who is dying, the family will pull away. Grief response, bereavement mourning. Maladaptive response, goes on for extended period of time, has a negative impact on the person who is grieving, weight loss, loss of sleep, isolation, may result in loss of self-esteem. Types of maladaptive response. Delayed, no grief at time of loss, grief triggered later, maybe years later. Distorted, individual fixed on anger stage, feels helpless and depressed, chronic, prolonged, unable to let go of grieving behavior. Nursing care with working with families and dying patient. Offer spiritual support, answer all family questions related to care of the dying patient, may need to assist in transfer to hospice, encourage family to express all their emotions and feelings. Erikson stages. Trust versus mistrust, which is hope. Autonomy versus shame and doubt, will. Initiative versus guilt, purpose. Industry versus inferiority, it's competency. Identity versus role confusion, fidelity. Intimacy versus isolation, this is love. Generativity versus stagnation, or self-absorption, this is care. Integrity versus despair, this is wisdom. So trust versus mistrust is 0 to 18 months. Autonomy versus shame and doubt is 1 to 3 years. Initiative versus guilt is 3 to 6 years. Industry versus inferiority is 6 to 12 years. Identity versus role confusion is 12 to 20 years. Intimacy versus isolation is 20 to 30. Generative versus stagnation or self-absorption is 40 to 65. And integrity versus despair is 65 to death.